Thank you, Chairwoman DeGette, Ranking Member Griffith. I appreciate the subcommittee is holding this hearing, and it's timely, and I'm grateful for the opportunity to participate. Most of us, members, witnesses in the Medicare Advantage organizations whose actions we've been discussing, share a desire to see the Medicare Advantage program succeed. With so many millions of people enrolling in Medicare Advantage and the number growing exponentially each year, it has never been more important for us to ensure this program works for patients. We know and have heard repeatedly here today that Medicare Advantage means a lot to a lot of seniors. It offers them options to decide what kind of health insurance they need when they reach age 65. Unlike traditional fee-for-service, Medicare MA plans with $0 premiums are often available, and 90% of plans include additional benefits like vision, dental, or hearing. We must continue to support the availability of plans like these for seniors who prefer them. But just because a program is the best option for seniors doesn't mean it's flawless. We've heard quite a bit of evidence today that there is room for improvement. I appreciate that every one of the witnesses who came here today has provided concrete ideas for how to improve the program. As you all likely know, I have a few ideas myself about how to improve the MA patient experience when it comes to utilization of services, particularly the prior authorization process. The Improving Seniors Timely Access to Care Act, H.R. 3173, has been mentioned a few times today already. It's a bill I've led for several years alongside my colleagues, Representatives Del Bene, Kelly, and Barra. Our goal with this bill is to facilitate the adoption of an electronic prior authorization process that is far quicker and more efficient than what doctors and patients currently endure. It also requires, as HHS to establish a process to facilitate real-time decisions for items and services that are routinely approved. It also has MA plans reporting their use of prior authorization and the rate of approvals or denials, and also encourages plans to use evidence-based guidelines in their prior authorization process. The result will be less administrative burden for providers and more information in the hands of patients. It will allow more patients to receive care when they need it, reducing the likelihood of additional, often more severe complications. In the long term, I believe it would also result in a cost savings for the healthcare system at large by identifying problems earlier and getting them treated before patients have more complications. As was previously mentioned, an EMA survey in 2020 of 1,000 doctors revealed that about 34% of them said that prior authorization has led to serious adverse events for a patient in their care due to delays in the prior authorization process. Most members of this subcommittee are co-sponsors already of H.R. 3173, and I appreciate that. Ms. Bliss, the investigation report the OIG released in April discusses 33 denials of prior authorization requests. I know there were requests that were analyzed came from all of the largest MAOs. Was the sample also representative of the Medicare Advantage program in terms of where the providers were geographically located or what the requests were for?
Thank you for that question. So we sampled from all of the denials issued by 15 of the largest Medicare Advantage organizations by enrollment, which accounted for about 80% of all Medicare Advantage enrollees. And so our results are projectable to the totality of denials across all 15 of those large Medicare Advantage organizations.
Okay, great. So I guess the answer would be yes, it does. It take into account geographical locations and what the requests were for. So Dr. Matthews, your recommendations include a mechanism for direct submission of provider claims to Medicare contractors. Has MedPAC considered whether that mechanism could be one that operated electronically in real time?
Yes, sir, we have. The basis for that recommendation comes from discussions with stakeholders who are currently submitting Medicare Advantage encounter records directly to plans, and sometimes the records are rejected by the plan without explanation, or there is variation among the plans that a provider works with respect to content and format of the encounter records. And some providers that we've talked with said there are other ways of submitting this information directly to CMS, the way they currently submit things like MedPAR records for all of their patients, whether it's fee-for-service or Medicare Advantage. And so we think there are ways that these encounter records on behalf of MA enrollees can be submitted with less administrative burden and more timely than perhaps they are being submitted now.
Thank you. In 2022, we should be going to an electronic process for a lot of these things, including prior authorization. I yield back.